Okay. So ultrasound guided. Yeah. Okay. Ultrasound guided dry needling for back problems. I think I have already gone through this. You want this to be done? Okay. Low back pain is the leading cause of years lived with disability worldwide. The low back pain includes discogenic back pain and facetogenic back pain, mixed pathology as in lumbar canal stenosis, low back pain due to spondylolysis, spondylolisthesis, and the spondylitis and spondylosis, which is mainly probably muscular. Mechanical back pain where your MRI, CT, and X-ray look normal. Piriformis syndrome. Sacroiliac joint also will mimic low back pain. Vertebral fractures from osteoporosis. Post-laminectomy pain syndrome or failed back surgery syndrome. And rheumatological pain, seropositive and seronegative conditions. Infections like TB, sepsis in the vertebral structures. And malignancy, either primary malignancy or secondaries from breast cancer, ovarian cancer, or prostate cancer. So low back pain has two components, the axial and the radicular. It's most common between 20 to 40 years, men and women are equally affected. It's called acute pain when it is less than 6 weeks. And usually it resolves by itself after rest, PT, medications, or hot cold fomentations. It is called subchronic if it is lasting from 6 to 12 weeks, or chronic when it is lasting more than 12 weeks. The actual cause of back pain, like infection, disc prolapse, etc., is found in less than 20% of patients. That means 80% of patients who come with back pain are the source of LBP is unclear. What we see in our clinic will always definitely have a cause because the simple back pains don't come to us. MRI, CT, X-ray are normal, called the non-specific LBP or the mechanical LBP. And genesis of back pain is because of lifestyle issues like lack of exercise, mental stress, vitamin deficiencies, all of which play a very major role. Sedentary lifestyle is the biggest culprit. Without exercises, it causes degenerative changes early in life. We expect degenerative changes to start after 40. But now what we are seeing is 25-year-olds, 28-year-olds coming with degenerative changes because of a sedentary lifestyle. The intervertebral disc is most relaxed in the lying down position. And at the end of the night's rest, it plumps up. It becomes nice and plump. And this is the reason why patients complain of worst pain in the morning, because they are pressing out on all directions. And this improves as they start moving around. So the disc flattens in erect posture. In lying down posture, it would have been little more like this. The disc has no blood supply of its own. Its nutrition comes from the surrounding tissues, which enter it as when we do exercises that bend the back forward and backwards. Like if the lumbar flexion is happening, the back gets stretched and it becomes the thin edge of the wedge is in front and the thick edge of the wedge is at the back. And when you do the reverse, it happens the reverse way. Like when you look at this, bend forward, the bulge is happening into the canal. And when you bend backwards, the bulge is happening in front towards the abdomen. So if you have the vertebral body here, the annulus fibrosus is all around a central fluid, the nucleus pulposus. And when this is the normal situation of a round disc, whereas in a patient who's got problems or a patient who's going to develop problems, who has no pain as of now, but the disc would have flattened and this round becomes something like a flattened oval. So you have the sinovertebral nerves which innervate the disc. They arise in the intervertebral foramen from two roots, one from the primary ventral ramus and one from the rami communicans. The rami communicans is the one which is coming from the sympathetic chain towards the root. They supply the posterior and lateral part of the disc. The disc normally also has this innervation, but only in the periphery, in the posterior and lateral part. They also supply the ventral dura and the longitudinal ligaments. With degenerative disc disease, the sinovertebral nerves start penetrating deeper inside the disc into the annulus and even reach the nucleus. This is abnormal. The periphery of the annulus innervated is normal. Basivertebral nerve is another nerve which is a paired nerve believed to play an important role in the end plate. End plate is, see, this is the end plate. So your basivertebral nerve supplies the end plate. The sinovertebral nerve supplies this part. And there are branches. The basivertebral nerve is a branch from the sinovertebral nerve complex. Patients with sinovertebral and basivertebral nerve pain presenting with radicular pattern of pain, they may present like this without a disc bulge or any such thing. Any significant radiological and endoscopic evidence of significant disc protrusions. See, when you don't think muscle, you have to find a reason for why somebody is having a mechanical back pain. This is one of the explanations given, the sinovertebral nerve and the basivertebral nerve. Are they really involved? If they are really involved, why do they respond to needling? These are some of the myths, queries. They might be true, they might not be true. We do not. So what are the type of exercises? Why do we say sedentary? The type of exercise that we want to do is repetitive flexion and extension movements of spine, which draw the fluid into the disc and expel it with the reverse movement. These optimize the transfer of nutrient from the interstitial fluid into the disc. If you want a disc which is well hydrated, which is well nourished, you have to do this flexion extension type of exercises. Surya Namaskar is one of them. The namaz done by Muslims, they have what is called as a sajda. Sajda is something like this, like these two. So this also helps. Whereas when you do the gym type of exercises, where the back is fixed and then you are lifting weights, it actually raises the intradiscal pressure and puts a strain on the discs. This is something which is not understood by most people and even by the gym experts. As a result, they push everybody to do more and more weights without this kind of yoga type of exercises. They will land up with a beautiful biceps and a weak back. So walking is also a very good exercise, since the muscles of right and left sides come into action alternately with each step. Running is a high impact exercise that can gradually cause degenerative changes in the back, in the joints, knee and the hip. So the lack of nutrition and disc degenerative changes which happen, first thing to happen is the weakening of the annulus fibrosis. The nuclear material then can breach the inner annulus like this and cause a disc bulge. This is also called a prolapse into the vertebral canal. It extrudes right through the vertebral torn annulus, and that is called an annular tear. That will be an extrusion. It can also extrude through the vertebral end plates like this. It can through the end plates to form small nodes. And limbus vertebrae, which I'll show you later. When small numerous extrusions occur through the end plate, it is called Scheuermann's disease. All these are disc diseases. When it comes into the vertebral canal, the nerve gets pressed. But when it does not come into the canal, but it is going through the bone, then you will have all these situations, Schmall's and Scheuermann's and Limbus vertebrae. In all the above, there is a gradual progressive loss of disc height, partly due to extrusion of nuclear material, but mainly due to dehydration and degeneration of disc. When the nucleus pulposus has completely breached the annulus, that is extrusion. And sequestration is when the nucleus becomes one small little globule in the vertebral canal. So when a person is standing, there is a direct pressure like this because of the weight, which expresses pressures all around the disc like this. Whereas when there is a bulging disc, it goes out in one direction. Instead of all these, only one gets bulged. And when it bulges like this, it will hit the nerve to cause a pressure on the nerve root. That is what we are showing here. This is a normal disc, normal nerve. Here is a nerve which is bent and out of shape, and it is being pressed by the disc like this. Sorry. So this is a nice, healthy, dehydrated disc. That is what it should look like. This one. Am I showing it there? Yeah. But can I get that red pointer? This is not seen well. In this, can you give me? Not there. ठीक है, जाने दो, चलेगा. I'll go back there. Okay. This is a desiccated disc. We on? Okay. Yeah. This is a normal hydrated disc. This is also a normal hydrated disc. But this is a desiccated disc and it is coming out here. And here is a tear, which is very beautifully seen here. This is a contained disc. This is a prolapse. There is no extrusion here. So deteriorating disc health because of sedentary lifestyle causes extrusion of the nucleus right through the torn annulus, like this, and it will hit the nerve. Or it can form a pathway like this, which can get plugged in by blood clots and other things. And things may settle for some time. And after some time, again it comes. This explains the recurrent back pain symptoms in these people. Because as things are worsening, the body is trying to heal as well. And these are the sinovertebral nerves here at this part. So this, I don't know how to get myself out of this place. Yeah. Okay. So this is a hyperintense zone because something like this has happened. There is inflammation and that brings in water. That is what you see as a hyperintense zone. And this means that there is an annular tear, and that also means there is a tremendous muscle spasm in these patients. This is a chemical injury to the nerves. What's happening? I'm not able to go. No, it's refusing to, it's freezing.
So can you see annular tear without any symptoms?
I think if it is very mild.
This is chronic. Like patient had 5-6 years back, patient had one episode of back pain.
It becomes a chronic situation.
But you can see the annular tear.
That's what it goes on and on and on. It doesn't settle. When there is a tear there, it will always.
There is a next.
Yes.
Back side.
Okay. So, so now let me go into this. So what this is showing is the Schmalz node, which you see very commonly in the this one. And when it is at the edge, it's called a limbus vertebrae. There's a chipping off of the end plate at the end, and this is Scheuermann's. And in this, you will also see black dots in the white of the disc. And these patients come with very severe spasm when they have this problem. These patients have very severe back muscle spasm and pain. So, and they respond very well to needling. So Schmalz node is where you can see these are the Schmalz nodes. The disc breaches the end plate. Limbus vertebra is where the nucleus extrudes into the vertebral body, undermining the ring epiphysis. And Scheuermann's disease is where the disc spaces are narrow and irregular due to extrusion of the nucleus into the end plates. This is your limbus vertebra. And this is what I was telling you, that it gets black sort of shadows inside the disc. So these are called modic changes in the vertebral body adjacent to the end plates. This causes a collateral issue of disc degeneration, and it becomes a source of very painful back muscle spasm. So all these changes may be there. Can you see the amount of inflammation here? This is fluid. So there is a tremendous inflammation here. Naturally, there is going to be a very severe back spasm. Unless we go and address all this through needling, things won't settle for them. And as they keep struggling with this very tight muscles, they will protrude the disc out. The reduction of the cushioning ability by the disc puts a stress. If this is the normal facet, this round has become a compressed disc. It is going to load the facets. So there is never a disc issue alone. There is always a concomitant facet issue which goes on. So facet arthropathy is a part of disc degenerative changes. So facets are synovial joints. Nature has provided a very rich nerve supply to the synovial joints so that synovium senses even minute joint movements. You know at any given time that you are like this, you are like that. All these things are very well registered at your subconscious, unconscious mind and a conscious mind. Because the synovium is so richly has such a rich nerve supply, minute joint movements and makes adjustments so that you do not overbalance, you do not fall, and coordinates movements to make them smooth and maintain a balance during movements and to avoid injuries. The synovial membrane also has instant communication with the muscles because of the Hilton's law, so that it can coordinate all these joint movements. Every movement requires two opposing groups of muscles to balance the movement and to make it smooth. So the agonist and antagonist combinations can be any number. I think Priya also mentioned it. Psoas is the agonist for bending forwards, and erector spinae multifidus is the antagonist, and vice versa. Side bends, the agonist will be the paravertebral muscles of left versus right. The erector spinae quadratus lumborum of one side will contract and the other side will stretch. And rotation will stretch one side against the contraction of the other. So if you have, this is a normal spine, whereas how to get rid of this? How do I take this away?
Oh, that's not coming there.
It's not coming there. Okay, then it's all right. So back muscle spasm, especially erector spinae spasm, can strap the back in a straight position like this. This is the straightened spine. And loss of normal lumbar lordosis. But this can be seen on X-ray and MRI. But you can also have a hyperlordotic spine because of the shortened hamstrings and adductors. Okay, I should go back, is it? Yeah. So back muscle spasm, particularly of erector spinae and psoas, can strap the back in a straight position with loss of normal lumbar lordosis. This can be seen X-ray and MRI. They are all showing that. So facet arthropathy becomes a collateral issue of disc degeneration, as I mentioned. If the disc is having degeneration, there is always facetal issues. And muscles are definitely going to be involved because of the Hilton's law. So if you look at genesis of back problems, sedentary issues have made these muscles, the psoas, the quadratus lumborum, and the erector spinae, become stiffer and probably have MTRPs with taut bands. And these will contract and compress the disc with facet arthralgia. And then when the patient continues to be active, play cricket, bend forward, do all kinds of things, then there is a disc protrusion which can happen. See, these small muscles we always ignore. The intertransversus muscles, the multifidus here, the rotatoris, all these are also involved in the stiffness and in the MTRP formation. So sedentary lifestyle leads to stiffening of muscles with gradual development of MTRPs in the powerful paravertebral muscles and the psoas. Eventually, taut bands develop in these muscles, which can together compress the spine and disc. The stiff muscles are constantly vulnerable to sprains, and micro tears of muscle fibers. In addition, the facetal irritation suddenly makes things worse because of the Hilton's law. Then there is the annular tear, which will bring in a lot more spasm compared to the original spasm. So the chemical effect of the annular tears, etc., all these lead to further muscle spasm. So then you have the mind and muscle. The muscle mass in the back has a very rich efferent as well as afferent, that is musculosensory nerves, which goes to the anterior cingulate gyrus, involved in emotional and affective components of pain. These are the references which talk about this. And that means straight away there can be depression and dullness, etc., which is so typical of back pain. And muscle pain is inhibited by descending modulating pathways. Whatever has been described as spinal sensitization, inhibition, etc., applies to muscle pain as to sensory nerves. The muscle, mind, and emotions are closely intertwined because they have to execute the fright flight reflex. So that is the reason why the mind is intimately connected with the muscles. So you have the disc here, the main root here. You have the posterior primary ramus, which comes and supplies the multifidus and median branch. And this is the anterior primary ramus. This is the median branch. This is the lateral branch. The lateral branch goes, see, the median branch goes to the facet, and the lateral branches go to supply all these muscles of the back. The anterior root goes to the abdomen or the chest, and in the lumbar region, L1 downwards, it becomes the leg nerves. So it is the anterior root which is causing the radicular symptoms, whereas the posterior, the lateral, can cause back muscle spasm. So this is responsible for the axial pain. This is responsible for the radicular pain. So this is the genesis of disc prolapse, as I have told you. Abdominal contents and abdominal muscles are equally important. If these muscles are lax, then all the load comes onto the back muscles. So that's okay. And all these have many cross connections. The gluteus have cross connections with latissimus dorsi. The oblique abdominals have cross connection with the hip adductors, and the hip adductors with the quadratus lumborum. So all these are myriad interconnection between muscles and fasciae. So you have spondylolysis, that is the superior articulating process. This is the, if you look at this, sorry, where is the, which is a good, okay, I will take this. This is the superior articulating process, and this is the inferior articulating process of the facet. And in between the two, on this side, this is the superior articular process, and this is the inferior. At the neck of the scotty, if there is a crack, which can happen naturally in some people, that is called spondylolysis. In the pars, this is called the pars interarticularis, this area. And you have to go and inject this neck. This garlands the neck of the scotty. These are our patients where we have done the injection. When you do an injection like this, it also can go into the epidural space. So when there are unequal tractional forces between the psoas and the erector spinae, if the erector spinae is stronger, it will be a retrolisthesis. If the psoas is stronger, it's an anterolisthesis. All these are the changes where the disc, this vertebra has slid forward here, whereas this is anterolisthesis. You can see here. Now, for this listhesis, there is no treatment as an interventional treatment. Giving an epidural injection is not going to help much, other than probably relaxing the muscle temporarily. Whereas ultrasound-guided dry needling can really reduce all the problems in a very big way. So what we started out like this, if you look at the date, 11/4/2008, 13/11/2008, it has, and this is 2010, a big listhesis. This is a smaller listhesis. And here, I don't know why this thing is, it has come here. CD, a listhesis which was so prominent has become so much smaller after healing. So compression fracture, wedging of L1, bone has no innervation except at the periosteum, and it refers to muscles. Collapse of the bony trabeculae do not alter the periosteum much. So the pain does not come from the body, but from the facet. The wedging of the vertebra causes misalignment of the facets, and it is from the synovium of the facets transmitting to the multifidus and the erector spinae that causes the pain in these patients. So when they go and do a vertebroplasty, they are altering this. They are filling this a little, so they are reducing the pressure on the facet. That's a very expensive procedure and not without risks. Whereas if you go and relax these muscles, automatically the pain goes off. That's a simple and a cheap alternative to reduce the pain. So this is basically to explain the radicular pain. I will not go much into this. This is the common peroneal nerve distribution. This is the tibial nerve distribution. So if you look at the surface anatomy, this will be the iliocostalis, longissimus, and spinalis. The needling is going into all these things: spinalis, longissimus, and iliocostalis, and QL. The same muscles marked here. So this is to show how the needling is done. Here, sorry. No. Okay. Why is it echoing? Anyway, let it be. Here is the back muscle needling going on, and a local twitch reflex. So this is showing the radicular pain because of the sciatic nerve and its branches. So radicular pain, what it does is, this is a muscle shimmy being seen by itself in resting muscles. Whereas immediately after needling, there is a frenzy going on. After 5 minutes, very less. So this is just to prove that. So failed back surgery pain, is it really a failure of surgery, or is it actually a post-surgical pain masquerading as a failure of surgery? Or is it a case of overlooking a pain generator that was always there but never acknowledged? So the correct nomenclature to be kinder to the surgeon is post-laminectomy pain. But it is a post-surgical pain. It is also a failure of surgery, and it is also a case of overlooking a pain generator, which was always there. But anyway, let us be kind to our colleagues. Surgery adds another new dimension of a post-surgical neuropathy to back pain, which is common enough to start with. The central sensitization caused by preoperative pain, long before the surgeon comes in, from radiculopathy, that gets amplified by the post-surgical pain. Interventions like TFE or facet RF are unlikely to succeed in unwinding the wind-up of central sensitization that has happened because of the preoperative pain. So actually, a better treatment would be to give a continuous epidural infusion for 4 or 5 days if you are trying to solve this with just an intervention and not needling. So it affects motor nerves, neuromyopathy, leading to spasm of muscles, which were already contributing to the disc prolapse, or because of the facet arthralgia. They were already doing it. You are making it worse after surgery. So the TFE and RF address only the neural component and leave the myofascial contribution to back unaddressed. This is the one which gets outsourced to physiotherapists, where they will do myofascial release, a little needling, little exercise, and they will produce 5%, 10% improvements, which they will keep on crowing about to the patient. So this is the reason why FBSS continue to remain such a problem. The moment you come into needling, half the problems get sorted out. So why do the interventions fail? The intervention can fail because it is performed for the wrong indication, wrong intervention performed, or wrong discogenic pain gets addressed while the facetogenic pains are not addressed, or it might be an added SI joint pain or a hip joint issue. Intervention was indicated but technically did not achieve results. Wrong techniques. And intervention is incomplete or inadequate. Wrong level intervention, blind blocks without image guidance, interlaminar instead of transforaminal injection, single shot injection when a continuous infusion was needed. Like I told you, a continuous infusion may be a better choice than a TFE in such patients. And also the mistaken notion that our omnipotent interventions can influence the complex issue of failed back surgery, which is what is going on.
Continuous epidural where?
Into the epidural space, posterior epidural space.
No, post-surgical case you are talking. There will be a lot of adhesions, so you may not be able to locate the.
No, you can always go above, below. Don't go into the operated area. Go one level above and push the catheter down. Your fluid will, by gravity, go penetrate all over the place. You can also give Hyalase. So the failure is because of a lack of understanding that back is a complex apparatus with a multitude of interconnected mechanics. So you have the disc, you have the facet, you have the muscles, everything has to be considered. So the nerve muscle joint interactions are governed by Hilton's law, which you know. And synovial pain is actually expressed by muscles. And when you alter the muscles, the synovial pain will go down. Or you can go and give a joint injection if you wish. So these are all the studies which talk about all this, about back pain. I don't know whether we'll get all this in our studies, in our searches. Yeah, that I'll give you later. Anyway, these things. So,
Only last 5 years.
so these are all older. So MTRPs cause taut bands in back muscles causing stiffness, which impede all the movements of the facets. And this causes movements are essential for activities of daily life are impeded by stiff muscles causing synovitis. Repetitive spasms lead to more MTRPs. The crucial factor to be understood here is that there is a definite link between facetal pain and muscles. This vicious cycle has far-reaching consequences to all back problems. Every disc will compromise the facet. The facet will compromise the muscle. So ultimately, unless you look at all three, things won't settle. And nerves are located in intermuscular compartments, as I said. The nerve root is compressed between the psoas here and the intertransverses here. So this is a very intricate thing, disc prolapse or annular tear spasm, chemical, mechanical, nerve inflammation, nerve irritation, firing, muscle spasm in the myotomal distribution of the nerve, which can be radicular or back, intrinsic muscles of the back or down the limb. And all these muscles can cause intense muscle spasm around the nerve root foramen to cause nerve root entrapment and worsening situation. So when we focus on the facet along with disc or alone or a disc alone or a muscles alone, it will be a case of missing the bus. You can't say that I'll do dry needling and cure. This is where physiotherapists lose out. They can only do some dry needling, but they can't address the disc. FBSS would be a case of overlooking a combo of interdependent muscle pain generators. So here is a patient. This is an actual patient, which somebody did a thermal RF in this patient. And then very next morning, the patient bent down like this. And she was in this position all the time. This is because what happened was thermal RF did multifidus weakness and the psoas overdominance. And after only needling of all these muscles, see the lady standing. This lady used to, she also had Parkinsonism, which made this camptocornea worse. But she lived upright like this for several years. She's no more. She's one of my very old patients. This is, I reported this because this was a complication. And Shimonen says, disturbed back muscle innervation and loss of muscular support leads to the disability and increased biomechanical strain and might be one of the important causes of failed back surgery syndrome. So this lady in this patient whom I showed, above the scar, this is the amount of muscle. But at the scar, see the loss of muscle. This is seen on MRI. Whereas after our needling, I didn't go and get an MRI done again. She couldn't afford it. But probably we would have seen more muscle. So Teixeira is another guy. Huh?
Little depth you can make up actually.
Yeah. But
I have seen with the sessions of maybe.
it will. It will.
You just hit the bone first. It's so thin layer of muscle.
It like with 25 you will hit, later you can go to 40. So Teixeira et al. Have looked at 56 patients, myofascial pain syndromes in 85% of patients, neuropathic abnormalities in this number, trigger point injection and epidural infusion of morphine in 69.3% of refractory cases. So they have already commented that a myofascial component is important in FPSS. So epidural steroid injections, only a moderate proportion of patients show improvement in pain and functional level with interventional pain management procedures, including epidural injections and anesthesiolosis. All these are old studies, 2007. Intrathecal pump found that the improvement in pain and functioning on an average. So spinal cord stimulator, there are several studies which show that it is not very useful. Functional status is no better. One study. 12 months, 32% had experienced device-related complications. So all these are the negative aspects of spinal cord stimulator, but still this is the treatment of choice in failed back surgery syndrome. So all these, from the time I came into pain management, spinal cord stimulator has gone from a simple mechanism to tonic SCS, ERG stim, high frequency, high dose, high density stim, burst stim, tonic burst stim, DTM for glia, etc., etc. Where is the functional improvement? No. And this is a very significant study, 2022 study, Dhruva et al. They looked at 7,560 patients. This merited an editorial because they concluded that after 2 years of spinal cord stimulator, did not reduce use of opioids, they did not reduce pain injections, did not reduce RF ablation or spine surgery in these patients. Higher costs and complications. At 2 years, 1/5 of the patient required, 1/5 of 7,560 patients required device revision or removal. But in spite of all this, if you look at it, Americans will continue with this because it brings more money to the doctor, more money to the company. This editorial in 2023, they said this is an independent large study. There is no industry funding, so it's very significant. And their conclusion was improved function is more indicative of efficacy than just a pain score reduction. So we have achieved it already. But if we say it, we may not be heard. So they also went on to say publications of SCS is marred by authors who receive income from the SCS manufacturers. They've said it. They've said it. Small sample size and effectiveness of therapy should be judged by this. I think I'll call it a day. I think everybody is tired. Yeah. I have another easily, I think, some 10 more slides. Okay. Anyway, this is Dr. Mukund Joshi, by the way, this patient. And L45 median branch, I'm just going into it. L45 median branch supplies the erector spinae as well as the small muscles like the rotatorius, intertransversus muscle, etc. that form the roof of the nerve root foramen. So disc and muscle pressurize the nerve. Then when it goes, since L45 supplies the piriformis also, you get a cramp here from the spine and another here at the piriformis. This is called double band. Piriformis syndrome in addition to a discogenic pain. So this is the article which I wrote about, is it only the piriformis? Because you have the gemelli as well. These are the gemelli. This is our dissection where we have shown the piriformis, sciatic nerve. These are the gemelli. Okay, this is Dr. Mukund Joshi's situation. He was diagnosed as piriformis syndrome. He was diagnosed in Jaslok. So they did 2 CT guided piriformis injections. No use. CT guided. He's a radiologist now. So he went to a radiologist first. So they did CT guided piriformis injections. Two of them didn't work. Then one ultrasound guided piriformis injection. This I think was done by Preeti along with Ashwin Lavande. Together they did. So that means there is nothing wrong with the injections. They have done perfect injections. But he did not do better at all. He was bedridden because he couldn't stand up. When he came to me, I said the only answer for you. His problem was he was a failed back surgery. After surgery, he got osteomyelitis of the pedicle. That was the problem. So obvious, and he was put in bed for I think probably 3 months. And after that, he came with this pain, and he couldn't stand at all. So then, when I saw him, I said, "Sir, I have the choice of giving you a steroid at L45, or I have the choice of doing needles." So he said, "No, no steroids for me." So we did. They injected local steroid. Yeah, which one? But at the end of it, he had got probably 80 milligram steroid floating in the piriformis.
Why no steroid in
Because he didn't want me to go to the spine. He didn't want me to go to the area of operators, which I was not too keen on either. Because scientific people don't believe in needling. So I gave him that option. But he said, no, 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 do needling for me. I did needling of the gluteus maximus, piriformis, etc., and the gemelli. Pain down within 2 sessions. He was back to work. He was climbing stairs and things like that. He became all right. But after that, after 2 sessions, he stopped. And then he, after some 15, 20 days of working, he comes back and says, "Lakshmi, I have a severe pain here." I said, "Sir, I have not addressed all your muscles. You needed to come." So he came, once we did all the needling, everything settled. And he got much better. This is Nene's gift, by the way. This is a patient. No, no, I'm just joking. This is one patient that's different. There was a patient who had post-surgery. There was a tear in the dura and there was a, what do you call it? CSF leak. CSF, CSF pseudocyst. So what Nene did was he went to this pseudocyst under CT guidance and injected steroid. It didn't help. See, this looks very attractive to a surgeon. He feels that is the cause. That is your question. You have been polluted by Ashirvad thought processes.
Even otherwise, anatomically also.
No, that fluid may be pressing on some nerve. So he went and gave the steroid, but didn't work. So this patient came to me this patient was from Panvel, I think a retired major. He came to me. I said, "Okay, we will do needles only for you." Or did I do epidural? I don't remember. I might have done an epidural and then I did needles. He did well, but not too well. But in him, I put him on this one Duragesic patch, 12.5 or something for that little pain which was left. Next time when he came back, he was thrilled. All pains gone, totally gone, and he was all right. So this looks very obvious, but that's not the cause of his problem. Okay, sorry, this computer suddenly decides that it doesn't want to work. So this you know very well, Jyoti Kumar. This is a person for your, you've also seen Jyoti Kumar. You haven't. He's a doctor who wanted to retire. He was in Oman, he wanted to stop working and post-surgical pain. I said, facet is your problem. He said, no, 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 I have done facetal procedures in France and England and one in Mumbai. So I won't do it. I said, no, 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 that's the way to start. We did that. He did better. Then needling kiya, sab chala gaya. I had to repeat his RF about 3-4 years later. Then he completely forgot about it and then came to give me this, saying that I went trekking in Leh Ladakh. Okay. So I think we will leave all this. Okay, thank you. Okay. I hope for you people you have understood why we do so much of needling as we do routinely. Any questions, or the question is only when is food? Huh? What do you mean?
Yes, but
I make